and welcome to the Nurse Rosa's Insights podcast. I'm your host, Rosa Hart, and today I'm joined by Bram Duffee. Thank you so much for being with me today.
Thanks for having me. I appreciate your invite.
Yeah, so you are a paramedic and an academic, right? Is that a good description of you?
I know I kind of do a lot of what is sort of a split life. I am a paramedic in Houston where I work full time, and I also am a communications professor. So I teach for Kennesaw State University, which is a university in Georgia, as a communications professor, but then I'm also a paramedic and do research. And, you know, it's sort of people say the official word would be scholar practitioner. But in the world today that we have, where there's lack of funding for research, and at the same time, a lot of need for healthcare, I'm sort of in an interesting spot, and I'm happy to, be here to talk about it.
Yeah, and I'm really looking forward to letting you put your perspective out there because you are in a very niche space. And so, first of all, let's dial it back to where did you come from? Like, how did you come to be? Were you a paramedic first? Like, did you go through EMT track first and then decide you learned to teach, or what was your pathway?
Yeah, people ask me how long I've been a paramedic. That's a pretty common question I get. And I just tell them my whole life. This is really what I've been interested in. I was
Since you
like, when I was
were
a
three.
kid, I was a lifeguard when I was a kid, and I was always involved in first aid stuff. My mom was a nurse who was a nurse educator, so she taught a lot of CPR classes, and I was basically enculturated into the lifestyle pretty early on. So I became a paramedic at 19 years old, and yes, I of course went through I was a first responder and then an EMT before that, and it's just kind of cool because it's something I always knew I wanted to do. And I know a lot of folks out there, maybe they bounce to different careers, maybe they're not sure about what they want to do when they grow up, but I was pretty sure. And becoming, working as a paramedic was something that I just did while I was going to school at the same time. And so I do have like this split world of communications professor and paramedic. And what it's allowed me to do is to spend a lot of time thinking about how do we communicate with folks in the healthcare environment. And that's what I write about, and I would like to talk about. I like to talk about and trying to make that space for the patient, especially a patient who's going through an emergency, trying to make it a better environment for them.
Yeah. Well, I think your path is really interesting because a lot of people see academia and teaching as something that you do when you're done clinically, when you're done practicing a lot of the time, or something you don't imagine an EMT doing. Because usually I feel like the stereotype might be those are the people who are not as interested in the book learning and they want the excitement and the hands on action, right? They're like, send me towards the
Mm-hmm.
danger or something like that. Would you say that stereotype generally lives up to that, or is that generally wrong?
It's a hard question to answer, but I can tell you that I am just able to do the things I enjoy doing, right? And so a lot of folks look at me pessimistically and they're like, well, why didn't you become a physician? And the true answer is that, this path that I have gone has allowed me to all this stuff. I just like doing it. So I don't watch a lot of television. I don't do some of, my life is I spend time with my dogs and I spend time in, reading and working on research. And it's just sort of all fallen this way for me. But I am lucky because I think folks sometimes connect school with negativity or with something you just have to do. And
Mhm.
I found a way to, move through school and enjoy it.
Yeah, and yeah, you are very interested in communication. You've written at least two books, right? Is it more
Hmm.
than two books, or am I unaware of two? Or
It's like there's stuff in progress. So I have a textbook that's been out for a while. It's a communications textbook. I also wrote a book that talks about how to use hypnosis as a paramedic. And so that's a book that was put out by Routledge called Hypnotic Communication in Emergency Medical Settings. And that book was popular enough that it was picked up in the German market. So it got translated and it's out in German as well. And then I am working with another group from London, and I have two other books that that I'm working on. But the kinds of things that I do when I write have to do with also my enjoyment, and I think that one of the passions that I have is trying to take this emergency environment for a patient and try to help them get through it. Because in healthcare, especially in emergency medicine, we talk to patients kind of rough. It's sort of like, and it's a whole culture thing for everywhere. We are focused on finding out what's wrong, fixing the emergency, and that emergency, a lot of times we see it as that we need to do something. We need to put an IV in, we need to give a medicine, we need to give oxygen. Okay, those are tasks. And by us not thinking about communication as a task also, I believe that we're really hurting our patients. And because I work in the environment every day, it has become my passion because I see it. I see the things that paramedics and nurses say to family members and to patients. And it's not like we mean to do harm, but there's a point where I think that it's not just professionalism, it's beyond that, because folks even use rough language, and it's almost like nothing matters except the skill part. And so I'm on this life campaign where I want to help change that. One of the things that I've written about that's sort of pulled this all to light is there's this physician from the 70s in Kansas who did a research study looking at paramedics and how they can use their words to positively influence a patient's condition. And that was, the 70s was a long time ago, but that kind of research has been around since then. And one of the things that I work with as a theory is we really believe that there is this physical part to the communication that happens between you and a patient. And if you just think about it, if someone speaks in a positive way or in a negative way, whether you're sick or not, you do feel that,
Yes.
and so if you're a patient who is in an emergency situation and maybe you're having chest pain, maybe you have a difficulty breathing, or you're bleeding, and the nurse or the paramedic connects with you as the patient, you're really vulnerable. And the psychological theory that I subscribe to, that I talk to folks about, is this idea that when you're in this heightened emergency state where fear is activated and you have this life threatening, or at least potentially life threatening situation happening, that your body allows you to be susceptible to a trance, this hypnosis type trance. And once you see it as an emergency worker, as an emergency nurse, as a paramedic, it's really easy to catch on to. I would say about half or a third of the patients that I come upon are folks who are in this hypnotic trance already, and so
Now,
you can see it. And
is this different from what we might call somebody's going into shock?
yeah. So usually what I will see is that if a patient is going into a state of shock, this is just something that accompanies it. But I think of this as like a psychological shock, But when we have a patient who, is in that vulnerable position, physically and mentally, then the words that you say as the authority figure, because they're in this state of hypnosis already, those words really matter. And so I know that it can change how a patient feels. If you think about someone who you walk through being able to breathe better, or to feel less nauseous, or to have less anxiety, all of those things can actually translate to life-saving elements for that patient that has asthma, who's having a heart attack, who's, you
Right.
know,
And it can
these.
count as its own intervention. I think what you're talking
Mhm.
about, and you tell me if this is what you're talking about or if I'm not getting all the way there. But like when I was working bedside in the ICU with people who are critically ill, worst days of their lives, and it's scary, I really prioritized establishing trust as quickly as possible and letting them know that, my intention is to take care of you. Okay. And so that way they knew, for one thing, I'm in their corner. And then a lot of the times people would say that me coming in the room was better than drugs. And because it does have that effect, right? When people
Mhm. Yes.
sense your kindness or your intention to help them, it has that physiological effect on them, lowers their blood pressure. Just like turning off the news can
Mhm.
lower your blood pressure. Because if
Yeah.
you're listening to words that are stressful and full of um, angst, we have a physiological reaction. Is that what you're talking about?
Yeah, and it's exactly that. What happens, we're talking about the ICU setting right now, but I'm more oriented with the emergency setting where a paramedic would, come upon the patient who's asking for help or their family has called. And right now, if you haven't gone through this situation, it's okay because it's not anything you want to
No,
experience.
no,
If you
thank
have
you.
a paramedic that comes to you for a life, to try to make sure that nothing is wrong with you, you basically a lot of times get a paramedic who's going to give you an interrogation because in their mind, they need to check off the list and make sure that there's no life threats that they need to immediately address. And I've been guilty about this myself as a paramedic because I am anxious as well. And so when I come upon a patient, I have all these questions that I want immediately answered so that I know that I don't need to like fix something or do something.
Mhm.
And so that moment that you talked about of getting on the patient side and establishing the rapport, it doesn't necessarily happen so well in emergency medicine. And so a patient can, feel like they're just being smacked from all kinds of directions, like with this interrogation. And it's like, it's pretty aggressive because, you're asking, do you have any heart problems, lung problems? Are you diabetic? Do you have any seizures? How old are you? When's the last time you went to the doctor? Do you have any allergies? I mean, like it's just on and on and on. When did this start? How long ago? How does this pain feel? And it can just be a lot.
Yeah.
And so that's why I write about and I talk about that. And incidentally, when we talk about stress and what paramedics go through. I wrote a article in Social Science and Medicine a couple of years ago about what paramedics go through in their most stressful moments, and I subscribe to the fact that unlike what most folks may assume, where if I'm doing CPR on someone or if I'm conducting the life-saving skills that we talk about, many people may think that that is one of the most stressful things that a paramedic can go through. But what I talk about in my research article and also um, what I've experienced is that the most stressful thing for a paramedic is really between the time the alarm goes off for the 911 call up until they get to that patient. And um, the reason is because, they are worried that, even if it's a cough patient, that's an automatic respiratory thing. That's, like it doesn't matter how small it is, there's a concern that there could be a life threat. So the stress part happens when the paramedic is trying to navigate to get to the scene to find the patient and so by the time they go through the mental anguish of being able to finally get to the patient, they are stressed and exasperated. And so it's a lot different than being able to do a skill that they're trained to do that's no problem because um, have it's something to do instead of something to worry about, right? And so we're
With
so well trained that
we
there's
have
there's a
that
difference there.
algorithm, right? If
Yeah,
this, then that with CPR, and and then you try to switch every 2 minutes if you can, and
right.
you know who does what part, and it's the known, right? But what you're talking about is that unknown and that wondering and
Mm-hmm.
trying to be ready for 100 different possibilities until you identify, okay, which one of these 100 things am I going to need to address and be ready for, right? Let alone, is the
Mm-hmm.
scene safe and am I going to be putting myself at
Right.
risk?
And so we clash that with, so this most stressful moment for the paramedic is happening at the same time that this rapport building actually needs to be happening with the patient, that this positive communication needs to be happening with this patient. There are ways to interview the patient without making them feel like they're being interrogated. And so these are the things that I really think can make a difference in how we take care of people in emergency medicine. And it comes down to, people say all the time that they want that they want to treat people like they do their family members, and as you get into healthcare deeper and deeper, that is just harder and harder to accomplish sometimes. And so
Well, and
this is part of it,
there,
is this culture.
have you seen how some people treat their family members?
For
Sometimes,
sure, for sure. Of course, I
sometimes
meant it with the most positive,
yes,
regard.
I'm sure you did. But at the same time, like, our family members get us when we're most stressed, right? And the real us
Hmm.
comes out. So, you know, maybe they are getting that a little bit. So,
Well, I know. And so the start of all this research back in the 70s happened with a research project that I had mentioned, where in each emergency, the paramedics would take care of the patient. And after they did the interventions, after they established the rapport, they would usually read from a card, but nonetheless, they would have a standard statement that they would say, where in all of their patients, they would make this statement that sounds something like, I want you to know that the worst is over. Everything at the hospital is being prepared for you. They already know that we're coming. Things look really good. I want you to know that I'm here with you, hanging out. The noise that you hear outside is all, part of what we're used to, things being normal for how to help you. And I just want you to know that I'm here right now. So those those kinds of statements, or some kind of statement like that, is just not heard is unheard of. Even in nursing, we talk about therapeutic communication in nursing, and there's not a focus on this particular physical slash mental traumatic moment, for the patient. And we really see this about in the first hour. So after a patient has, experienced like a severe onset, or, something like that, then it's a moment where, it's not a moment, it's a period of time where you can see that the patient does things mechanically, meaning, like, instead of just reaching for something, it would take 3 steps instead of the one. Eyes are, whoop, microphone went. Eyes go wide open, mouth is usually open. It's just because they're ready to take in information. And
wow.
so if you are a physician, or if you're a nurse, or if you're a paramedic with a badge that comes upon someone who's in this state, the words that you use are incredibly important.
Yeah.
There's this term that I've used that's been out for a while, called nosemic communication. And it's something that I've written about, and also Andy Newton has written about it. And what this is it's sort of the opposite of the placebo effect. And we know that, so this is the way we label this kind of communication.
Can you describe that?
Yeah, so
Let's talk
it's,
about the difference between a placebo and nocebo.
yeah, so
Anybody who's
if
not familiar
we
with that.
so a placebo would be like, if we just think about how we could talk to someone in a positive way, and that could deliver that positive feeling, right? And so even though it's not delivering a medicine, this is still, like we mentioned, this is an aspect of a positive communication that fills a person. And so that is in many cases known as a placebo, right? And we talk about the placebo effect, about how that can be used in some situations for a patient who thinks that they're getting medicine, or has a mental connection with the understanding of the illness, right? So most regards, we're talking about anything with a placebo effect as being positive. And so the nocemic effect is just the opposite of that. It's where negative words and negative expressions can hurt the patient because you're filling them with negative energy. I think that one of the most common things I see is that folks who are in this state, in this mental state, will assume that everything in the environment has something to do with them, and rightfully so, because these are folks who are potentially, in a bad physical shape or in critical condition. So the way that we speak around those patients, can make them think things that don't have anything to do with them, right? We could be talking about another patient or another situation or an inside joke, or, these are all things that we don't talk about as potentially,
Harmful.
influencing the patient and how they feel and their outcome.
Yeah, that is really interesting. And a lot of the times people have verbalized that they hear on the inpatient side, they hear the nurses laughing outside in the hall and they wonder, are they laughing at me? Right? Because
Yep.
all they know is their own experience in that moment. And so many people come out of the hospital with delirium and PTSD from, yes, the, trauma that they experienced, but then also sleep disruptions and just
Mm-hmm.
all that stress just really weighs on people's minds and that can last for years. And so I think what you're talking about is, preventing a lot of that damage that can be long lasting, isn't it?
Yeah, and to your point about the long lasting aspect, I think back about, and I write about this in my book, I think about this little girl that I took care of one time who was mauled by a dog. And so the dog had torn up this little girl's face pretty good. And of course, that meant there's a lot of bleeding, and everyone, especially the adults, are very animated about, the situation. I just remember thinking in that moment, first of all, as a paramedic, this little girl's going to be fine. And I knew that, right? And so after I got through my own, concern about that, and now I'm able to sort of look at this whole situation as a movie around me where I see all the adults freaking out. And in that moment, I recognize that, okay, what's happening with her is going to get fixed by plastic surgery. She's not going to die. And I know these things. But the other things that went through my head at that moment and that have influenced me even now are that I know that the things that I say about that dog, the way that we communicate around that little girl about what happened to her is going to mean the difference probably if she ever has an experience that's positive with a dog ever again in her whole life, right? This is how people get to be deathly afraid of dogs. And
And
I
you said you're
have
a
three.
dog person,
I
right?
am.
So
I
you're
am. And this is the thing. I've had dogs my whole life. I have three right now in the suburbs. So like I'm like into this dog culture. And so I know that, you know, that that this is a path that can change people's lives. And so, it makes so much sense for a little girl that would go through that. But as an adult, we have to recognize that we can go through that too. And that we're not, it can be just as bad.
yeah. So were you able to speak to those adults and address the situation in a therapeutic way
Yeah.
or
Yeah. And so what happens is that unfortunately, you have, it's sort of a weird dynamic because you always want the parents to be with the child because that allows comfort to happen on both ends. But when things just get to be so incredibly bad that everyone is influencing everyone in a more negative way and things are just like emotionally piling on each other, the then the child needs to be removed from the situation. And so that's what we did in this case. So we had the little one in the ambulance while basically working for bleeding control and doing like a wet to dry kind of
yes.
dressing thing. So yeah, so once that was underway, then the adults could be spoken to outside, and so it allows it allows for a separation that will let us be able to take better control of the situation and also hope calm everyone down. But The truth is that there are lots and lots of situations where it's almost impossible to help everybody calm down. And so in those cases, it's about not just saying, hey, everything's okay, going through the steps of letting them know that you're on their side
Yeah.
by establishing the rapport, and then working to explain what's happening in simple terms, and also along with that, how we're working to help them. And if we skip any of those steps, then we're actually missing a lot. And it doesn't matter, because, and it does matter, but also if we're within that first hour of this traumatic onset, then it's sort of a double whammy.
Well, and a lot of people feel like we're doing things to them, not necessarily for them, and
Mm-hmm.
probably right. I mean, not that they're rightly so, because we are doing it for them, but it is important to let people know that there is a reason for why you're doing things, right? Otherwise,
Mm-hmm.
it's all Greek to them or Latin, as the
Mm-hmm.
case may be. So it might be really simple things like, all right, I'm going to start an IV in your arm to give you some fluid and just to narrate what you're doing. And that can be soothing to just let them know that this is not mysterious. This is, you know what you're doing, and it's letting them know what is happening to them.
Mm-hmm. Yep. And it makes so much sense. But in the actual event of the emergency, the way that the stress of the paramedic is facing the emergent situation, those steps get skipped, and that's why I like to talk about it, and I like to highlight, some of the ways that this can be better for the patient.
Yeah, exactly. And, the more ingrained it is in you, the less you have to think about it. And I'm sure if you're able to come to the point where you're able to think about someone else, that helps regulate your own emotions too in that moment, right?
Yeah, it's like once you recognize all of this that's happening around you, it's sort of like in the Matrix movie moment where you see yourself, you see the situation, you see the people interacting in the situation, and you sort of are able to dissect and, understand what's happening. And it makes it less stressful, but also more interesting, because it's almost like, I know that people do sales jobs, and sometimes, like, folks that are doing sales jobs, they go through this, sales process of trying to convince someone something, right? And sometimes the reality is that as a paramedic, we're going through a sales process too. Like, and if we aren't able to talk that patient into going to the hospital, especially if they really need to, then that could mean the difference of them living longer or not. And so
That's a
the
lot of
way that
responsibility.
yeah, I think so. And that's why I am not someone that has, tattoos or piercings. My haircut is, high and tight, and it's because I know that a lot of the patients that I interact with are going to need to trust me. Like, and if I can't convince them to trust me, then it may not be good for them, And I think about folks who are older, that when they see these non-traditional styles of hair or whatnot, it might be harder for them to trust. And so, because I have been a paramedic my whole life, and the outward projection mattering so much, this is all influenced, um, my thinking in these moments. I kind of think of them, like I said, as matrix moments, because I do know why I'm stressed. I'm stressed because I've worked so hard to get to this patient, and now I'm worried about, what things might be triggering for, life threat concern, and the patient is in a hypnotic state, and the family members are potentially also in a hypnotic state, or, where I see a lot of parents who exhibit these signs, and it's in a lot of cases where the child is not in a life-threatening situation, but because they are so emotionally connected and concerned, that we have to be careful about how we talk to the parents in those situations, because it's just like the little girl with a dog bite. These interactions are potentially going to affect them forever. I don't just need them to trust me, I need them to want to call an ambulance again if something ever, if ever happened.
And you're right that like they're going to latch onto that experience. I know in my peds and OB rotation in nursing school, They were telling us about the like emotional connection that a woman feels with the doctor who delivers her baby, because it's such a because she gets flooded by all these hormones at the time of birth, and it gives like this extra layer. It's not just a huge like life event objectively. There's like a chemical reaction like sealing it in, and like 30 years later you see this person and you just have all these feelings of connection with them, or with the nurse who is holding your hand while you're pushing or whatever it. And it's similar, like your adrenaline is going and you're in a really stressed situation, and so these people are given to be part of a really bad situation or a really reassuring presence in the middle of it.
Yeah,
But
and
if you're
that's
if
such a
there
fantastic way of describing that. My best friend just had a baby, and so like I'm just thinking about this, the same kinds of things that you're talking about that happen. It's just like even gallbladder surgery, or even even these things are scary, really. And so having that assurance matter.
yes, it really does, it really does. Like, being a nurse is like, I'm pretty comfortable in a hospital, but I had to have my gallbladder removed, and I had um, SCDs put on my legs, and I burst into tears because I was like, I'm not supposed to be the patient. I'm supposed to be the one putting those on people, not have them put
How am I
on
going to
me.
get up?
No, just like it was like an identity crisis. It was just like,
Yeah.
oh, I'm in the wrong place. Like, do I?
Well, the hardest thing for me as a patient, the hardest thing for me was the fact that they were all concerned that I was going to fall, and I had a bed alarm on me, and I'm like, y'all, no, this is too much. But yeah, and because when the bed alarm goes off as a patient, you don't know how to turn it off, and it's like you've
Right,
been caught. It's almost like you're stealing from a store or something. You
right.
can't fix the problem, and now
There's
you
so
know you
much.
weren't supposed to get up because you told them that you wouldn't. But then that
Also,
was my worst thing.
but I couldn't reach my charger. Right. I
Yeah, there's always a reason.
I had candies next to my bed actually, and my husband was asleep on the like bench thing, because it wasn't really a bed. It was kind of supposed to be a bed. Um and he was asleep, and I couldn't reach the call light to call the nurse, so I was like throwing pieces of candy at him to wake him up because I was like too weak to holler at him. But I don't think I had a bed alarm on, or could have shifted my weight substantially and just set that off.
Well, they put one on me.
If there was one thing that you could communicate to every EMT or every nurse or doctor about how to best communicate with people who are in this hypnotic shock state of being, what would you want to make sure they know about how to communicate with people in that moment?
My main thing is that there's a need to protect those people from negative thoughts, words. And so if you're in a position where you're on scene with a patient, the outside influence from bystanders can really matter. So maybe we need to move that patient to a place that is not going to allow them to hear all that negative communication. And then the same thing in the emergency room. Like, okay, maybe we have this patient in the hallway and we need to get him into a room because
Ooh,
there's just too much negativity that they're going to be absorbing, and we need to protect them right now. And as a healthcare professional, once you start to recognize this hypnotic vulnerability, this state of hypnosis, it's almost like you can just look up from your desk and say, "Oh yeah, they're in that position," just with the facial expression and with the mannerisms that can come with that we notice. And I know that I'm a communications professor, so it's sort of my thing to notice subtle cues. But the more that I talk about it, especially with my colleagues, they can see it in patients also.
I
And
mean,
so
we are
it's
here to visually assess people. So, I mean,
yeah,
we already are visually assessing people for all kinds of things. And so it makes sense to do that. Now, I think when I hear the term hypnosis, I think about suggestibility, in that,
yeah,
you think, oh, they were hypnotized and now they're going to go do this thing and they're not even going to be aware
yes,
of it. But that's not really what you're
yes.
talking about, is it?
So yes and no. So when we talked about that little girl who was going to be like living a life with or without dogs in her life, that's connected to the fact that she just went through this hypnotizing moment.
Hmm.
And especially as an adult, there's not a way there's not a way to hypnotize someone without them agreeing to it. Because there's a real partnership that happens with hypnosis.
Hmm.
With children, it's a little different because their imagination scale is just so high that they have an easier time latching on to authority figures and moving through hypnosis. But adults, especially, like I said, there's a partnership there. And so anytime you see these stage hypnosis folks and see them at work, you might notice that out of a group full of a lot of people, they just end up dismissing half the people that they bring up on stage. And some of that is because they are recognizing that they are not vulnerable to the trance that they're trying to work out. And it's not a vulnerability it's a vulnerability that's there because the patient allows it, or the person allows it to be there, which is different than what's happening with these patients who are going through these traumatic events, right? So
Because
if
it's
you
being
go into
done
a hypnosis
happening.
office, you know that you're going to be hypnotized. But if you're in a traumatic emergency, then it's just a vulnerability that happens to you. And so that's why I think that at the very least, we have to protect what these patients hear, and and recognize that hypnosis is real. And it's just that, unfortunately, there's been a lot of creative hypnosis entertainment that has really hurt the messages that I am conveying, right? Because there's been years and years of just entertainment. And I know I'm in a weird position because I'm saying that some of that entertainment was legitimate hypnosis, but for that to happen in those staged hypnosis moments, those folks had to say, yes, I'm willing to come up on stage. They're allowing themselves to do that. It's not like some special, magical thing. Hypnosis is not something that can be done unless there's a partnership there, and that's why when we look at how we are interacting with a patient, that rapport building part of the communication is just really important because we want them to trust us. We want them to believe us, when we say positive things to help them.
Yeah, definitely. So it has come time for me to ask you the question that I ask every guest on the Nurse Rose's Insights podcast, which is, if you were given a grant for $1 billion to meet the needs that you see in healthcare, how would you like to see it used strategically to have the most sustainable impact?
So, right now, what I personally see is that research funding for healthcare is being cut across our country in a really aggressive way. And I am a podcaster. I host the podcast EMS Research with Professor Bram, that's sponsored by the Journal of Emergency Medical Services. And
Mhm.
some of the people that I interview on my podcast don't have jobs anymore. And it's just unbelievable that, I know this life saving advancement in healthcare is now being demolished, and so it takes years to pick up the pieces and start over once some of these research projects are finished. So that research is a big concern of mine. Other part of that is when we look at research that's specific to paramedics,
Mhm.
there is very little research that happens in the United States. Most of the research for EMS that is academic comes from Australia, Canada, the UK. And that's why I have research connections in those places, because the EMS research is just really limited. Probably, if I were to have answered this question a few months ago, I would have been selfish and I would have said, if I have all this money, I would put it into EMS research. But now I'm telling you that because we have demolished research in healthcare right now, that everyone needs it. And I don't know about you, but I want to live a long time, and I am not just in a position to to think about that for myself. I think about that for my patients, for my family members. And, you know,
Yeah.
the way that we're going to get there as a society is by, working to do continuous advancements. And I found out about the closure um, of an Air Force project just a couple weeks ago that is going to mean the difference in how we're able to control bleeding in trauma patients. And it's
That's awful.
and yeah, and there's also new advancements in what resuscitation could look like when it comes to trauma patients and volume. So these are things that I was just like so excited about a couple of months ago, knowing that, okay, now we're on a fast track
Mhm.
to implementation that I don't know how it could happen now. And so it's not just my field, it's cancer, it's, all the neurological things,
Yeah.
everyone right now.
I think you're absolutely right. I do want to push back a little bit right now in that, in so much as I think it's a good opportunity for reevaluation and prioritization of, if we can't assume that the government's going to do it, what needs to be a priority, and stepping up and pushing for that. Like, I've seen so many people who are more private investors and interest groups are funding research for things around menopause and women's health specifically, which, you know, all of this drug funding that's been happening since the 70s, they were studying men and not women. And so the dosages are not
Hmm.
accurate for women. And
Yep.
so while these things have been getting funding, there's a lot that's been left undone, right? And so I think, just silver lining, not saying that it's not a terrible situation, but like, what can we take away from this and how can we move forward? I think this is a great opportunity for you to vocalize and say, this is the kind of research that we need to be prioritizing. This is the kind of research that I'm heartbroken is set back, and really push that to whoever might be able to fund it, whether it's, some kind of private company or a nonprofit or something like that, or raise awareness around it. And because we can't assume it's just going to happen because the government knows what's best and is going to look out for us, we have to advocate for the research that we know can be impactful.
I know it. That every researcher out there probably thinks that their research is the most important, but I
I'm sure they do.
I just know.
So you need to start watching the women's health movement, and maybe they'll find out something interesting about like clotting speeds in women versus men, or maybe something can be revolutionary about like how much fluid you need to resuscitate a woman versus a man or something. Maybe it's not just weight based. Maybe there's a bunch of hormonal aspects that we haven't considered, right? I'm not saying necessarily that the good news even exists in the area that you want it to yet, but like, that's the purpose of this podcast already, is to put out into the universe, what is it that we want to see, and how would it make a difference so that somebody else can grab onto it and run with it. Because you're already
Mhm.
doing really good work. You are pouring your energy and your blood and sweat and tears into teaching and doing research and educating, as well as putting into practice what you've learned about this therapeutic communication with
Mhm.
vulnerable patients and your vulnerable colleagues. And so they're benefiting from working with you and learning from your example. So you are making the world a better place where you are. And then you're using your voice on your podcast to put these ideas out there. So the world is a crazy place, but at least we're doing our part to make it a little better, right? So, Bram, I really wish there was a way we could tell if somebody was actually in any kind of state of hypnosis versus just, I don't know, they're in a vulnerable position. Like, what have you heard about that?
So one of the cool things is that we've been able to find research studies that look at how patients can be put into a PET scan machine. And a PET scanner is something that's just used to isolate whatever you tell the machine to isolate. So in this case, it's commonly used to to look for cancer is what PET scanners are a lot of times used for. But in this case, we look for how the brain is using glucose. And so it's really cool because you're able to put someone into a PET scanner, see that there's a particular pattern that the brain of use of glucose that shows up on the screen. So, what makes it difficult to research is that, when we're looking at patients who are in this vulnerable state, within the first hour, putting them into a PET scanner is not reasonable. And it also doesn't necessarily like tell us anything that we need to do extra. So the way that they've done this research is they, like in a lot of hypnosis research, they have found folks who are highly hypnotizable. So there are folks that are highly hypnotizable and use those folks for these kinds of things. So they're not people who have been through a traumatic moment. They're people who've been put into an induction of hypnotic trance instead of being sort of exploded into it by a traumatic or a medical moment.
Yeah, so some people can like go in and out of it pretty easily due to,
Yeah.
do you think it's like genetic, or is it more like they're trusting people, or is there a personality element? What do you think?
So there are folks who are more visual, um, are usually thought to have more abilities when it comes to being able to move in and out of a trance state. But we have to know that all of us do it all the time. And one of the common trance states that people talk about is the highway hypnosis, right? So you don't even remember how you got someplace because you drive
Oh,
that route so often. And these are true things that happen to us. But there are some people who have just practiced that to the point where they're really good at it, and those are the people that we commonly use in research. A quick funny story is that my younger brother was sort of not buying into this idea about how he could himself ever be hypnotized, and I just thought it was really funny because all I had to do was remind him how many times I have to call his name to get his attention to snap him out of a television session, because his whole life, I just know that he, once he turns the television on, he gets really, glued into it. And I let him know that is, a hypnotic state that you're
really?
experiencing.
So, it,
Yeah.
well, does that mean you're more susceptible if you get really glued to the screen?
You're allowing yourself to. So it's sort of just like other hypnosis part. You're allowing yourself to be, come into that world, and people do it in, different. There's different ways of doing it, right? Like that's why sometimes people like going to the movies so that you can sort of totally, surround yourself with the visual and the feeling versus the other ways that you might absorb something.
Yeah, yeah, that does sound like a less harmful way, depending on what you're watching, maybe. But okay, well that's really interesting. I need to look into this like pattern of glucose usage in a hypnotic state. That sounds interesting. Do you remember who did that study, or
Yeah,
is there a series of studies?
it's referenced in my book. It's like in the first chapter.
So there we go. We gotta check out your book and see. Okay.
Yeah, that's the thing. I'm going to be speaking at the EMS Expo in Indianapolis about EMS research, and then I'll be doing my monthly podcast where I will continue to work to highlight things that are happening in EMS research. What I do in my podcast is a lot of fun because I basically spend time looking for research that's interesting that people would want to learn more about, and that's what I put out there. So it's not always life saving stuff, but it's always like interesting stuff.
Well, the quality of life saving is equally important, I think. I don't know if you saw it, but I had someone else on this show. She has her own podcast, Christina Rodriguez, and she has a podcast called Outcomes. I think there are several called Outcomes, but it's the one by Christina Rodriguez. And she has a list she puts out frequently on Substack of the Fundable 15. It's all about social determinants of health and what programs are being implemented that you can fund them. They make sense for ROI. I think to your point of what you were saying with you had these people on your show and their research is getting cut or they don't have a job anymore. Maybe you could put out like a list of these are the people I know who lost their jobs, whose research has been, and if you've done this, please excuse me, and I will
No, I
just
haven't, but
okay,
yeah.
I would appreciate it if you put out a list of these are the people that I've had on my show who were talking about their exciting research and now it's at a standstill and they lost their jobs. If you like make a list of it and be like, this is why I think it's important, and I would love to see them get backing and just kind of use your platform to maybe connect them to someone who can breathe new life into that.
Yeah, that sounds like a great idea. I know that I think there are efforts underway in that, but not specific to the EMS world. So, but yeah, that sounds like a great
And if
idea.
you put the list out and then people find them, you can always be like, yeah, it's because I put it out there. You can't take credit if you never did anything,
Yeah,
right? No, you put it out and I'll reshare it.
right on.
Yeah. Hey, I think that's a really important role that us podcasters play is connecting people who would not have met otherwise or would not have taken
Hmm.
the time to like I don't know about you, but I get tons of requests on LinkedIn all the time. I want to have a call and it's like I don't know if I have time to talk to everybody. I would love to, right? So sometimes you need to know how they talk to somebody else, listen in on their conversation and really get to know if your values are aligned and you're in sync and need to work together.
Yeah, and in my case, I just feel like that everyone benefits from positive communication. And especially, everyone wants to live a long time. Everyone wants to feel good. So,
Mhm.
to be able to get there for everybody is it's a different journey, I guess. And one of the things that I think is interesting as a paramedic is that I get to go into all these different hospitals, and I know that some places the staff really likes their job, and other places I know that they're probably not treated so good by management. And it's really interesting that organizational culture also can influence this, because
Mhm.
it's just so true that you're um, if you have workers that you're not treating well, then it's hard for them to project on positive thoughts, and it matters a lot. I think about patients that are dying and the words that they're hearing,
Yeah.
and
Yeah.
it's not just that you want their last words to be positive or anything like that. It's that you're there as a nurse or paramedic, you're there to preserve life. And so being able to think about being soothing and protecting that patient and connecting with them they're not things that are on the checklist, so to speak, that I'm working to put them there someday.
That's what we got to do, man. We just got to rewrite the rules. I mean,
Yes.
we're waiting for the grown-ups in the room to do it. We grew up. It's us.
I know.
I was listening to Sam Altman the other day and I don't try to take any of what he says as advice, except he did say that when he was little, he assumed the grown-ups in the room had all the answers. And then he grew up and he learned that nobody knew what they were doing. And then he was like, I have to be the grown up in the room. I don't think it means you have to have world domination, but I think it does mean maybe we have to just do what we can and not assume somebody else knows better unless they prove it.
Yeah, and
Right?
I think that you and I are kindred spirits like that. We're both doing that.
I think so. We're not limiting ourselves to certain roles. We're doing like five different things at the same time because we love it. Just like you and I, we're not getting paid to be here right now. We're talking to each
No.
other on our off time. Like probably like I don't know about you, but I'm sleep deprived, but I didn't want to miss this opportunity because there's that synchronicity there and we can feed off
Hmm.
of each other's positive energy and then go forth and make the world a better place together, right?
Yeah, let's do it. Now, before we go, is it okay if I highlight a couple of books?
Please. I was going to put them
So
in the show notes. So go ahead
no,
and
but these are, I'm not being paid for this like either, and these are not my
oh, these are
books.
not
But
your
I just want to
books.
mention that no,
Yeah.
I just want to mention that James Tripp, he's a hypnotherapist. He's a hypnotherapist from the UK, and he's written a book called Hypnosis Without Trance. So
Oh,
even if you're this does you do not have to be anything healthcare to dive into this. But if you're interested in how people's words can be influential in a hypnotic kind of way, this is the guy. So James Tripp. And then I mentioned the research study from Eric Wright in Kansas in the 70s. And since then, and before me, Judith and Prager. It's Judith Acosta and Judith Prager wrote a book called The Worst Is Over. And I just want to highlight that because this is a really nice orientation to how some of the statements that we can make with our patients can just make a really big difference. And so they're the ones that first sort of brought that to the mainstream. And then, of course, my book, which is Hypnotic Communication in Emergency Medical Settings. This is great if you're an ER doctor, a trauma nurse, or a paramedic. This is how I talk about ways that we can work to communicate with patients in these serious moments. Patients that have been raped, or patients who are near death, or patients, who are having heart attacks. These moments deserve a special kind of attention sometimes.
Right. And I would assume, not having read your book yet, that it might need to be more succinct in those situations due to time constraints than maybe those other books that we're talking about, because they have the luxury of time.
Yeah, so it's like that's why we can't necessarily look at everything in a checklist kind of situation, because when the moments that we're working with the patient lend themselves to, sometimes we have an opportunity to express a nonverbal positive expression in a moment, right? It's not like we can always do things in certain steps in certain ways, but what we can do is we can protect the patient from negative communication. We can bond with them, let them know that we care. And then just what they did in the Eric Wright study in Kansas, after those interventions are done and after that rapport is developed, we can give them a positive statement to let them know the worst is over. Everything's going to be okay.
Yeah.
And, when I was at EMT school, back when I was like 17 years old, one of the first things that I learned about was that I, as an EMT, am not supposed to tell someone that everything's going to be okay. And the reason why is because I don't know if everything's going to be okay. And I was shocked way back then, and I'm still sort of fighting that mentality now, because I think that so much emergency healthcare directly withholds anything positive, and that
And
is
by
doing damage, and I believe that.
positive, you mean hope.
For sure. Yes.
And I'm not saying that I believe in manifesting anything, but I do know when you say things enough times, you start to believe it. Or if you hear something said enough times, you
Yes.
buy into it. And we have to allow space for hope.
Mm-hmm.
And we can't authoritatively say, I have a crystal ball and I know that you are going to be okay. But we can provide reassurance, like you were saying, positive things like, we've got you, or if we're
Mm-hmm.
handing someone over, you're in good hands. These are exactly who I would want to have taking care of me.
Mm-hmm.
Or, this is a really scary situation right now, but you are not alone. You've got a whole team of people, and all we want to do right now is help you. And just
Mm-hmm.
really focus on the true things that are positive, that are hopeful, even though you're not promising a certain guaranteed outcome.
Yeah, for sure.
Yeah. So I think we got this. What do you think?
Yeah.
All right. Well, if you guys if my listeners here enjoyed listening to Bram Duffee, you have plenty of other opportunities on his podcast as well. Can you tell us the name of it again and where they can find it? Are you on YouTube
Yeah,
or
so
audio platforms?
it's everywhere. So EMS, if you just type in EMS research, it's EMS research with Professor Bram, and I am on YouTube and all the podcast platforms that there are, I think. And I also, my next speaking engagement, if you are working in emergency medicine, the largest EMS expo in the country is coming up in Indianapolis next month. I hope to see you there. Come find me. If you saw me on this podcast, I'd love to say hey.
That's right. And if they want to connect with you, is LinkedIn the best place to do it? Or do you have another website or anything you want people to check out?
So all my stuff is open. It's really fun to put me in Google because you can find me. So you can catch me on Facebook Messenger, on LinkedIn, on Instagram, and email. I teach for Kennesaw State University, so you can find me through the university websites as well.
Okay. Well, that's all. He is not hiding, you guys. So you
Right.
can find him 5 different ways. That sounds right. Are you on social media? What's your handle?
So I don't know off the top of my head, but if you type in my name, you should find me, Bram Duffee, Duffee.
It helps to have a very unique name, doesn't it? Yeah. So, well, if you enjoy that, find him. I'll link to several of those options in the show notes. It sounds like there might be too many to put in the show notes, but I'll link to some of them there and the books that he referenced so that you can find them as well, at his own and the ones that he mentioned. And then if you enjoyed listening to the Nurse Rose's Insights podcast, please subscribe and leave me a comment, or just, follow if you're on YouTube or on any of the audio platforms. Make sure you hit the notification bell so that you will get notified when a new episode drops. If you know someone who is a healthcare stakeholder, hint, hint, that's any human person who has an idea of how we can make healthcare better, please point them in my direction. LinkedIn is a great way to connect. Also, I'm on pretty much all the social medias at Nurse Rosa Speaks, which will be in the show notes as well. So I'd love to meet them, and I hope to see you in the next episode.